looks like the impact that could be achieved by the group here with the right strategies could be much more profound than what we're able to do on a day-to-day basis in the US. So I'll be speaking on systemic therapy, what is realistic in the low and middle income country setting. A very different topic than I'm used to speaking on, but nevertheless I'll give it a shot here. Okay. I work with a lot of pharma and biotech in early phase trials, so here are my conflicts. Okay, so this has been covered by a lot of the speakers, so I'll go through this fairly quickly. So most common primary cancer of the liver, viruses, and alcohol are the more common etiologies here. In Western countries, NASH and NAFLD is a much more prominent etiology. Of course, this is a huge global burden in terms of the age range it affects, so not just mortality and morbidity burden, but also an economic burden. If you look at the etiologies, these etiologies, again, was covered by other speakers, but you can see that hepatitis B, hepatitis C is predominantly found in what we consider low and middle income countries, and I'll get to that definition in a little bit. And then even alcohol consumption, particularly in parts of Eastern Europe and Russia, are quite significant in terms of the etiology. So these all play a major role in terms of HCC in these countries, and these are the same countries that have less in the way of resources from an economic standpoint. If you look at World Bank definition, that's how we define low and middle income countries, you can see that these are largely distributed in Africa, Asia, particularly Southeast Asia, Eastern Europe, and Central and South America. And these are exactly where the etiologies that I showed you cause HCC. So I'll start with anti-angiogenics. And here we're talking about patients who can't get surgery, transplant, if that's feasible, depending on the country setup, or as Dr. Sarkody outlined, local regional therapies of some kind. So liver cancers are known to be fairly vascular tumors, as you can see on the scans and the pathological specimen there. And at our disposal, we have at least now 4 small molecule inhibitors shown here, SORAFENIB, lenvatinib, REGORAFENIB, and CABOZANTINIB, and 1 antibody, which is ramucirumab, which I won't talk about in this talk. Okay, so if you look at the data, the data for SORAFENIB came from the SHARP study, which was the first randomized controlled trial in advanced HCC patients that showed a survival benefit, and this was done mostly in BCLC patients with fairly preserved liver function, which would be Child-Pugh A. And the study was conducted primarily in Western countries and Asia. Again, what I'm seeing in most of these studies is that Africa and Central and South America are not represented, so it's all extrapolations that we're making. And maybe there should be a mandate in the future to really have these regions of the world included, because that's where there's a significant disease burden, and without that it's quite incomprehensible how we can continue doing studies without Africa especially being included. So there was a separate study in the Asia-Pacific region which showed a survival benefit as well, and again, same design, SORAFENIB versus placebo in the types of patients I described, more hepatitis B patients in this study. So if you look at the data from both the studies, even with therapy, median survival was less than 1 year in the SHARP study, and a bit lower in the Asia-Pacific study, probably because local regional therapies are used much more significantly in that part of the world, and hepatitis B related HCC has a more malignant etiology. Few patients responded, meaning decrease in tumor size more than 30%. But as we know, these types of drugs are more cytostatic and generally keep the tumor size about the same but shut down the vasculature. Okay, so a recent study was done that used another anti-angiogenic, lenvatinib, which has a slightly different toxicity profile compared to sorafenib. This was a non-inferiority study, so going into it, we weren't going to be better than sorafenib. Again, this was in Western countries and Asia Pacific. So as I mentioned before, it was a non-inferiority study, so you're not going to see any benefit over sorafenib, at best, not any worse. So you can see from the survival curves, we don't need to go much into the statistics even, that they almost completely overlap, and this just gives you another option to use in place of sorafenib if toxicity profile is a consideration. However, this would come with an economic cost because sorafenib should soon become a generic drug, and the cost is going to become considerably lower, whereas lenvatinib is a drug which still has a considerable patent life. So no difference in other endpoints that were really significant. Here you can see progression-free survival appears better, but OS is the same. So I think these drugs are very interchangeable in terms of efficacy. Only differences would be some toxicity profile. Some higher rates of response with lenvatinib, but if you're talking about advanced patients, this really shouldn't matter too much. Perhaps there may be some niche role in those patients where you might use this drug to get downstaging for surgery or transplant in borderline resectable cases, or patients who progress on local regional therapies but are still being considered for transplant. Okay, so the side effects for lenvatinib are similar in nature but slightly different in frequency. So more hypertension but less hand-foot syndrome and more hypothyroidism. So rash, diarrhea, these types of toxicities could be maybe avoided by using this drug compared to sorafenib, if that's a consideration. I'll go into sort of the beyond first-line setting now. So if you look at this graph, it conceptually explains what happens if you give an anti-angiogenic. You slow down the disease, and at some point you're going to have increase in the size of the tumor compared to baseline. So if you don't do anything, you'll go back on that slope, and if you give another anti-angiogenic, maybe you can keep them on that decreased slope. So that's really the concept behind all of the drugs that are used in this space. So I'll highlight two studies here. Again, I don't know how relevant they will be in the LMIC setting unless costs decrease. So hopefully some of our industry colleagues are here in the room, and if they want to make a difference, one of the ways is to decrease the cost. Okay, so the RESORCE trial evaluated regorafenib, again, versus placebo. If you remember that slope of curve idea I gave you a little bit earlier. And this was a almost 600 patient study. And you can see that the overall survival was increased in the regorafenib group versus the placebo. This was across all subgroups, so there's really not any selection of patients you can do, so there's no biomarkers per se. Angiogenesis is a very common phenomenon in most liver cancers. If you look at other efficacy endpoints like progression-free survival, regorafenib was better as expected given the survival data. And most patients don't get tumor responses, only 6% or so patients had responses in the regorafenib group. And I always see about a 2 to 3% number in the placebo group. So there's some spontaneous responses that occur in HCC patients, and those remain unexplained. Toxicities for regorafenib are very similar to sorafenib, so high blood pressure, hand-foot syndrome, rash, diarrhea, fatigue, all very similar to sorafenib. In fact, the molecule differs only by one fluorine molecule, so not unexpected. Now we'll get to the sort of meat of the matter. So if you look at regorafenib, a cost-effectiveness study was performed. So efficacy is just the beginning of the equation in all countries, not just low and middle income countries. And in the Western world, the agency that's best at doing this is probably NICE in the United Kingdom, where there's many drugs approved in other parts of the Western world, and in UK they have separate economic evaluation to see if it's worth it. So cost-effectiveness analysis was done with regorafenib, and it was shown that the increase in quality life years and other measures was very minuscule. You can see in this graph that it would start becoming effective only at several $100,000 US currency per patient. So obviously that exceeds the per capita income of most low and middle income countries by many, many fold. There's no further discussion when you have a therapy that's so expensive. So even when these are priced at a quote unquote discount in other parts of the world, it still exceeds that threshold, and therapies are just not accessible for economic reasons. So again, if our industry colleagues are in the room, please take these messages back to your superiors. The goal here is to make a difference. If you look at CABOZANTINIB, this is another study in that sort of second and beyond line setting with anti-angiogenics. Again, the design was CABOZANTINIB versus placebo with a 2-to-1 randomization over 700 patients. The toxicities are very similar to the other drugs I mentioned. Most patients had one prior line of therapy, but some had 2 prior lines, so also some data in the 3rd line setting. And vast majority had other anti-angiogenics, and some had immune checkpoint inhibitors, which I'll speak to in a little bit. Okay, so if you look at the survival curve, you can see that you get a few month median survival improvement with CABOZANTINIB in this 2nd and 3rd line setting. And again, the effect is across all subgroups and not unexpected, which means you can't select out a patient population that will benefit. You just have to give the drug to anyone who would have 2nd or 3rd line HCC. Side effects are what you find in this class: rash, hand-foot syndrome, high blood pressure, fatigue, diarrhea, etc. And if you again look at the cost effectiveness, a very minuscule improvement in quality of life year assessment given the very high cost of the drug, again in the several $100,000 US range. So it becomes a non-starter for use in any of the regions of the world where the burden of the disease is the highest. So quite ironic, unfortunately. In China, there was a study some years ago looking at FOLFOX, which is typically used in other gastrointestinal cancers, such as colon cancer, gastric cancer, now biliary tract cancers. And they compared this to doxorubicin in a randomized trial. Here is the schema for the randomization. Again, the one limitation here is that this was an Asia only study, so we don't know how this would perform in Africa, but maybe this would be the type of research that could be done here to see if this is an option as a regimen. And here you can see that there was a survival benefit at some of the interim analyses. The top left corner there shows the separation of the survival curves at that first interim analysis, showing that compared to doxorubicin, which was considered the standard prior to that, that FOLFOX is a regimen one can use, even in hepatocellular cancer. And the toxicities are what one would expect: myelosuppression, neutropenia, thrombocytopenia, anemia, neuropathy from the oxaliplatin. And these are all higher compared to doxorubicin, where you get some myelosuppression, but it's a single agent. Okay, so a cost effectiveness was done for FOLFOX versus SORAFENIB, and it was shown that only at fairly low cost would SORAFENIB become cost effective enough compared to FOLFOX. So actually, for most low and middle income countries, if we were to extrapolate the Asian data for FOLFOX to other parts of the world, it would be a reasonable regimen to consider. Now, things may change considerably once SORAFENIB becomes generic, or in those countries where their policies allow them to make SORAFENIB as a national emergency. What about things other than systemic therapies? So should one use antiviral therapies in these advanced BCLC C patients in addition to, or just in place of systemic therapies? So here's some elegant work that was done by investigators from China, and they showed that use of hepatitis B antivirals actually led to a survival improvement even in these advanced patients, both from overall survival and progression-free survival efficacy standpoint. You have clear and nice separation of the curves. So from a cost-effective analysis perspective, this could be considered possibly a viable strategy in LMIC countries, and something to consider when systemic therapies are maybe not feasible. At least try to use the antivirals. I'll go briefly into immunotherapies, although if the challenges with anti-angiogenics are so high, are these things more just fantasy at some level? So if you look at CTLA-4 antibodies, these were studied in hepatitis C patients. Small trial here, only about 20 patients. Much larger randomized trials are now being conducted, which I'll get to in a little bit. But just as proof of concept, you get toxicities in the liver due to autoimmune effects in the liver when you use these drugs. And consistently, you see about a 20% durable response rate. So if one is looking for significant duration of response like you get with surgery or local regional therapies, then I think the immune checkpoint inhibitors are probably the way to go for most countries, rather than investing in things like SORAFENIB or lenvatinib, where all patients, even at the end of the treatment, pass away and get typically less than 1 year of benefit. So as I mentioned before, about 20% of patients get response, and these tend to be fairly durable, lasting several years. I have a number of patients in my clinic that are 3-4 years out already, some who stopped treatment several years ago. So this is definitely a transformative mode of treatment. If you look at NIVOLUMAB, where there's the largest body of data, this is a PD-1 inhibitor, which is probably the most studied immune checkpoint. And here's a study that's now been published for a few years, looking at 3 cohorts with hepatitis B, hepatitis C, and then non-virally affected, mostly NASH and alcohol. The doses ended up being the same in all the cohorts, despite separate dose escalations, and over 200 patients were studied in the expansion study. So if you see the effects of nivolumab, you get, again, about a 20 to 30% response rate. They can occur early or late. When they do occur, they are durable, as I'll show in a little bit. And even if you stop treatment, sometimes the effects can persist. So at some level, these treatments are trending towards what one can achieve in the surgical and local regional world. So if you look at the waterfall plots that I show here, over half the patients get some tumor shrinkage, and 20 to 30 go past that response line that's shown on the bottom there. And it doesn't matter what the etiology is, you get about the same percent response rate. Toxicities, apologize for the small font there, but mostly autoimmune phenomenon, a little less toxic than the CTLA-4 antibodies. You don't get as much diarrhea or severe gastrointestinal toxicities, but you get rash, hypothyroidism, fatigue. The most important one to watch out for would be elevation in the liver enzymes, again, because the immune system will start affecting the liver where the tumor is. So that's probably the only one to really look out for in these patients. Okay. Similar to nivolumab, you also have pembrolizumab, which is another PD-1 antibody. Same response rate, about 20%. I think you can study any PD-1 antibody and you're going to get about the same response rate. If you look at the survival curve, the median survival had not yet been reached, and that's because you have these tail of the curve patients that are the durable responders. And I think that number is going to end up being about 15, maybe 20% or so. We'll see in the phase 3 data for the trials that are ongoing. So again, while patients will have progressed, quote unquote, by a year, you have this tail of the curve, and that's because these are probably the durable immune responders, and that number is going to be in the 10 to 20% range. Okay. There's also a trial combining anti-angiogenics with immune checkpoint inhibitors. This is a PD-L1 antibody with BEVACIZUMAB, which is an anti-VEGF antibody. And here the response rate seems to be a bit higher, almost 30%. And these responses are lasting almost 2 years. So again, we're trending towards very durable outcomes. You can see that the responses are early, fairly deep, and that they persist. When you look at the tails here, they're lasting quite long, in many cases even after therapy is stopped. So a few phase 3 trials are ongoing. The Checkmate 459 trial is probably the furthest along. This was announced to be quote-unquote negative because it didn't beat sorafenib, but I think the data will show that it was at least trending towards it, and this might end up still becoming a new standard of care. And maybe median survival won't be the best way to look at the outcomes from this group. So very large study, over 1,000 patients, comparing nivolumab to sorafenib. I don't think there were any African patients in the study, but we'll see when they release the data. Again, quite unfortunate if that wasn't the case. Second line study looking at pembrolizumab versus best supportive care. The data has already been presented, and again, this quote-unquote didn't show superiority, but it trended towards a survival benefit, so it's more a quirk of the trial design than immune checkpoint inhibitors not being better than best supportive care. Okay, so a few conclusions. In LMIC and everywhere in the world, anti-angiogenics are efficacious in the first line setting and second line setting, depending on which ones you're talking about. However, if you apply that second bar of cost effectiveness, then none of them made it, and only FOLFOX, which is not in that group, would achieve that. Other methods to not forget about would be antiviral therapies with hepatitis B, and I hope these studies are also done with hepatitis C therapies. And I hope immune therapies can become available to LMIC countries because it does produce durable benefit. So I'll conclude there. Thank you.